The video on the CT images, please.
Yeah, briefly tell about the patient's background, please.
Yeah, this is a 68-year-old gentleman who's been diagnosed to have HCC in January 2014 on a routine evaluation for abdominal pain. His serology is negative, and on CT abdomen, it shows that there is a 7 centimeter by 4 by 5 centimeter lesion. Dr. Sumathi, can you scroll through the images, please? Can we scroll through the images? So we can see that there is a nice feeding artery which is going towards segment 6 and segment 7. And there is an arterial enhancement with washout on the delayed phase.
Can you just block the image? Yeah, can you stop there, please?
Can you stop scrolling and just show the image?
Just leave it
stop
there.
Stop scrolling and show the image.
Yeah, that's good. Comfort dinner.
Just 1 second.
Dinner. Please, we'll catch up.
Just 1 second. Just 1 second. I'll just show it.
Show them, and you're doing the same. So yeah, so that's arterial enhancement. That's the feeding artery.
Yeah.
That the screen on the right upper quadrant is too bright. I think you need to contrast that to show the washout. You can see the washout there. Okay, so that's good. We can see.
Can you still hear me?
Yeah, carry on.
1 second. I'll just show
it. Yeah, I think it looks like. Did the patient have known cirrhosis? Deepa? They'll come live soon.
Just scroll through this. We also have a coronal image wherein you can see that there is an extensive portal vein thrombus extending to the main portal vein. And you can see that there is a heavy vascularization of the portal vein consistent with malignant tumor thrombus. And as we go posteriorly, you're seeing washout of the lesion, which suggests that this is probably located somewhere in segment 6 or 7. So we've calculated the tumor volume, taking into account the portal vein thrombus as well, because it's a malignant thrombus. And we are ready to go now. So we've already punctured and ready to go.
Okay. Yeah. Can you just ask somebody to zoom into the CT image, show me the coronal of the portal vein, please?
Zoom it to the coronal of the portal vein. 1 second.
That's it. Go back. And zoom in.
Can we zoom it to the port? Can you zoom it, please?
There was a minimal on that, on the axial, what about the LFTs? The LFTs are okay? That's a diverticulum, I think. Up there? Yeah, left duct. See, the ducts are a bit up. Yeah. Deepa?
Yeah.
There is some ductal dilatation. Was that there on the...
Sorry, I can't hear you. Sorry?
Was there any biliary ductal dilatation, any LFT derangement, please?
There is no biliary dilatation. His bili now is 1.5.
What are you showing?
Sorry, 1.06. So this, his LFTs are fine.
Okay. Vivek made an observation that we can see some ductal dilatation.
There is a very subtle ductal dilatation. I wonder whether this is because of the hypertrophied arteries which are around there. Pretty much similar to portal cavernous transformation, which causes very mild ductal dilatation. So it could be because of that.
Okay.
But clinically, he's not obstructed, he's not jaundiced, and his bilirubin is fine.
Great. Okay.
Yeah. So we'll carry on with the punctured has been done by Sriram already.
Okay.
So we'll carry on with the engaging the artery now. Yeah.
So basically, in summary, we've got a large tumor which is involving major portal vein involvement. So clearly, as we were discussing, the treatment options are very minimal. In a palliative setting, we're obviously planned. So this patient a week back had the lung shunting study, which is a prerequisite. Is Dr. Sumathi there? Hello? Hello?
Yes?
Is Dr. Sumathi there?
Yeah, she's around. Just 1 second.
Hi.
Hi, Dr. Sumati.
Hi.
Right.
Hi, Dr. Uttapa.
Can you please tell us about the lung shunting study? What is the process involved, and what was the lung shunting, and what its importance is to the audience?
Yeah, lung shunting is basically done as a radioembolization. Just a minute, I think I need to just put
We
on
can
my
see you.
apron.
Yeah.
And
put a lead coat on.
Yeah.
And then you can stay in the room or you stay outside. Keep talking.
Yeah, can you hear me?
Yes, we can hear you.
Yeah, so basically lung shunt is a preliminary step in the workup of radioembolization. And this is important because most of the HCCs have direct AV shunting. And therefore, there is a high risk of the radiation particles to be deposited in the lungs, which can thereby result in radiation pneumonitis. So it's very important because at any one point of time, the permissible dose to the lungs should not exceed 30 grays. And the limit for cumulative dose is about 50 grays. So this is a very important step. And along with that, when we do a mapping angiogram, we're also looking at the anatomy. So what we use is basically when after the mapping angiogram is done, at the end of the procedure, depending on what kind of a treatment, whether it's going to be a super selective or a selective or bilobar treatment, we place the catheter in the artery intended to be treated. For example, if we're treating the right lobe, we'll place the catheter in the right hepatic artery and then infuse technetium MAA, because the particle of MAA size is almost similar to that of yttrium. So it actually simulates the true treatment. And after about, once the patient is stabilized, and within a period of 1 hour, we shift the patient to the gamma camera room and we do a whole body and static images as well as SPECT images and do a quantification of what is the percentage of the particles which have deposited from the hepatic tumor to the lungs. And if the shunt quantification is less than 10%, it's well within permissible limits, we just go ahead and plan for the treatment. However, if it is above 10%, we can still go ahead, but we can just reduce the dose so that we don't exceed the permissible dose delivery to the lungs.
Okay, thank you. While they are getting ready, on the workstation, can we pull up the lung shunting study at all?
Yes, I'll try to do that. Yes, I'll do that.
Yeah, if possible. Okay, so please keep explaining what you're doing, Dr. Deepa and Sriram.
Now we have engaged, it's a conventional anatomy wherein the proper hepatic artery is coming off the celiac. So now you can see C2, which is already engaged and it is in the right.
Okay, keep proceeding.
So what we are doing now is, can you hear me now?
Yes, very clear.
Okay, so you can see that the forefront C2 is already in the right hepatic artery.
Okay, that's good. Yeah, can you zoom up the image now, please?
Yeah, can we zoom the image, please? And as you can see, there is, its tumor is coming from segment 6 and segment 7, so we need to engage the right posterior branch.
Perfect. So for the audience here, basically you're seeing a lot of tumor blush as the dye comes out. We are seeing a lot of irregular enhancement there, and actually it's going downwards into the portal vein. So that's why we can actually look at the angiogram and correlate with the CT, saying that there is arterial enhancement of the portal vein thrombus, therefore saying it's tumor thrombus rather than bland thrombus. So all that information is available in CT, but then we reproduce that by doing the angiogram. So that's the main catheter, which is placed into the right hepatic. Now they're going to try and go super selective to the feeding artery with a microcatheter.
Can you appreciate the tumor thrombus in the portal vein? So what we are seeing is, you can see that there is a blush along the portal vein, which is probably the tumor thrombus. Screen? Okay, we don't have to go any distance. Stop there. Enough. Yeah, stop. Enough. So this will be the point of embolization.
Are you going to do an angiogram through the microcatheter?
Yes, yeah.
So now you can see the main catheter here, microcatheter into the branch. Now we're going to try and do an angiogram to try and demonstrate the vascularity and make sure we're in the right place. Also, when we do a microcatheter injection, we are making sure there's no reflux. Therefore, while we're doing the embolization, we've got to be safe that there's
because there's a little bit of a tumor which is, yeah. So I'm not going to do it from here.
Embolization of any of the GI tract branches.
We're just going to compare with the previous lung shunt planning angiogram to make sure that we park the catheter in exactly the same position, so that the the lung shunt, whatever lung shunt we had.
Is the microphone close to you?
Sorry?
Microphone close to you, please.
Close to me. Can we have the mic, please? What I was going to say was we are going to compare with the lung shunt that we did, planning angiogram lung shunt, to make sure that catheter is parked in exactly the same position as the lung shunt.
Perfect. Yeah. Just show us on the reference monitor.
Yeah. Can we show the lung shunt on the reference monitor, please?
So what they're trying to show is when they did the lung shunting, the planning
angiogram
studies done the previous week, they want to reproduce that same image so that we know where the microcatheter should be placed, and therefore then before we start the treatment. I think in radioembolization that's one of the paramount importance, that the technical aspect, you've got to be extremely meticulous in doing it, because like we discussed, these patients are really in a palliative setting, especially this patient has got main portal vein tumor thrombus. We don't want to be doing a procedure which is going to cause toxicity or give him a GI ulcer and affect his quality of life. So I think even if we get a partial response is good, but we should not give any toxicity.
Next.
Dr. Vanitha, ma'am, you want to add anything about the technical aspects and dosing?
Stop.
Right, yeah.
Yeah. So this is where we actually injected, because...
Please get the mic to 1 minute,
Oh, mic.
Test is done approximately 7 days before the main study.
Yes.
In that you use two different microcatheters, or you use the same microcatheter?
No, different.
In the lung shunting study, when you're doing with MA, you use the microcatheter and you go distally, or you just go proximally and inject the MA?
Basically, if you've got a large tumor and if you are beyond the GDA, you can use a normal 4 French or a 5 French catheter and do your lung shunting. Because the lung shunting will give you one role of lung shunting is to make sure how much goes to the lung. The second is we want to know technetium,
you inject to the main, always micro.
technetium deposition in the tumor. And the third is, while we're doing the angiogram, to make sure that there are no abnormal branches which are supplied to the duodenum or stomach or anything. So we don't always, for the lung shunting, need to use a microcatheter. Sometimes you have to, because for example your 4 French catheter may not reach there, then you have to use a microcatheter to get up to the tumor. Am I making sense? Or?
Yeah, but you don't use two catheters.
No.
We are ready.
Before the study, before in the lung shunting study, you use the same catheter in the...
No, basically what happens is when we use the microcatheter, if it is a serology positive patient, that catheter is thrown away. Then the patient comes back on the day of the treatment, like today, we're going to use new microcatheter and all that. So it won't be the same catheter at all. But we may or may not use the microcatheter for lung shunting, but on the dose delivery, you have to use a microcatheter because that's a safety mechanism where you inject. If you inject through a main catheter, you may inject too fast and you may get reflux, and that's going to be disastrous. So we always